This podcast represents my opinions and the opinion of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each person is so unique, please consult your healthcare professional for any medical questions that you may have.
Welcome back, everyone. We're back here with Dr. Tadros today. I'm your host, Vanessa. And today we are actually going to do something a little bit different. So in our pilot episode, we mentioned that one of the origins of this podcast, as well as the inspiration for its title, comes from Dr. Tadros' blog called Not Your Doc. So for today's episode, we're adapting an entry he wrote in May of 2021 surrounding commonly worded medical phrases with non-obvious meaning. So what we're basically going to do is I'm going to throw out some of these phrases, many of which will be familiar to people listening to the pod if you've ever been to a doctor and asked a question. And Dr. Tadros is going to give us a translation. As with a lot of topics that we'll cover on this show, Dr. Tadros, your perspective as an actual physician and your willingness to pull back the curtain for those of us who aren't is going to help us get some better understanding of how physicians think and then how they speak to patients as a result.
Well, yeah, thanks. Thank you, Vanessa. Thanks. How was your week?
It's going pretty well.
That was exciting stuff.
It's been busy, very busy at the clinic, but lots of exciting things happening.
Yeah.
So in reading this blog post, which will be available for our listeners to read in its entirety, it's going to be both in the podcast description and on our social media streams. I basically saw 4 categories of topics that doctors cover with patients that you wrote about in this post. Mm-hmm. The first one is managing patient expectations for procedures and treatments. So, for example, you write, before an injection to numb the area around an open laceration, the patient hears, "This is going to pinch/sting a little," or burn a little bit. Or after a patient gets a portion of their colon removed in surgery, the patient is told, "You will have a little bit of diarrhea for a while." So, objectively, a shot near an open laceration won't just sting or burn a little bit. And if you have part of your colon removed, you're not just going to have a little bit of diarrhea for a little while. So yeah. What are doctors trying to do when they say these things that just seem crazy understated?
Yeah, well, so the good news about it is not only my physician heard these statements, or sometimes I even said them earlier in my practice and my medical life, but I'm also a patient, and I have family that are patients. So I've been around, my father-in-law and my kids. So I hear it from both ends, both as a physician and as from my colleagues, and also as a family member. So sometimes when people use the typical English words, and this is in any profession, we have jargon, etc. But when we try to use the word pinch or burn or sting to describe a pain, pain is a subjective sensation.
Sure.
And for the vast majority of us, whenever we get an injection, it more than stings and pinches and burns. Especially if you're already scared or you're already in pain. That's part of the issue we run into. And then people kind of mistrust you or mistrust the nurse who gave them the shot, etc. So that's part of our problem. And when people say a little bit of diarrhea, if you're not used to having any diarrhea, you're not used to having any problems.
Sure.
A little diarrhea may set you up at home, and you may not be able to leave the house, sometimes for weeks to months, until, for instance, taking out part of your colon. It takes a while for the rest of the colon to step up and absorb the extra fluids so that you can get back to a regular stool, for instance. So unfortunately, when we describe these things that affect your life or affect your kid's life or your family member's life, we need to be a little more careful. We need to kind of give a range, and I think that's extremely important to give ranges: mild, moderate to severe, or best case, worst case, and average case.
Yeah, because it seems like saying, this, you'll have a little bit of diarrhea, or this might sting a bit, or something seems so understated to the point of being like almost misleading.
Yep, that's right. It feels misleading to the typical patient. You're right.
Okay, so that, and you're telling us that it's not the aim of medical professionals to intentionally mislead us about those expectations.
That's
it's just kind of how that people need to be more intentional, honestly, about how they're explaining things to patients.
That's right. And I've been yelled at twice for giving people too much information, so being too descriptive about something. But the vast majority of people, and it depends on age and background, etc. How we should describe things. So if somebody's never had a shot before, we need to probably spend a little more time. If somebody's used to shots, like I'm going to go get my booster for my coronavirus, my Omicron, I know what it's going to feel like. I've had several of these shots and previous shots also. So, and I'm an adult. So totally different perspective as somebody who's never had shots before or has a known phobia or fear of shots.
Okay. So here are a couple others for you. So one would be instruction to someone who is chronically short of breath at rest to, quote, use this rescue inhaler only when you are short of breath, not all the time. Mm-hmm. And then another too is, if a medical professional is trying to help figure out where pain is located for you and you say it hurts on my side and then they press here and they say, now does this hurt? Like, obviously it hurts and obviously I'm short of breath. So like, what am I supposed to do here?
Right. These are kind of mistakes that I made myself. I had one of my patients who was severely short of breath in my office repeatedly, and I would ask her to demonstrate how she was using an inhaler, and she would use it properly. And then finally I asked her when she actually uses it after a couple of visits, and she says, well, I never use it. I'm always short of breath. And and so I didn't think that I needed to use it because you told me not to use it too often. And so for me to put, worsening short of breath from your baseline, okay, you're always short of breath when it gets worse because whatever you got a cold or a respiratory infection, or you had to walk to the mailbox and now you can't catch your breath. So I have to define what the baseline is. The patient, and I'm the one that had to define it. The poor patient didn't know what I was talking about. So that's the first thing, is that you have to know what the baseline is. And then the same thing with belly pain, and this is the same thing. I catch myself, I laugh because I still picture myself. Somebody tells you it hurts in the right lower part of their belly near where their appendix should be, and you go ahead and press there and you ask if it hurts. Well, or it was already hurting. That's why they're seeing you. So does it hurt more?
No, it doesn't hurt when you push on it, actually.
It hurts more. So more shortness of breath than your baseline, more pain than your baseline pain. Does this make your pain worse? Does this, use this inhaler when your shortness of breath is worse? So these are ones that I made mistakes with myself.
So it sounds like some of the things that are just obviously missing from these statements are just like qualifiers of quantity or quality, right? Like how much or in compared to something would feel easier to answer and also maybe get a better answer from the patient.
I took Latin class, I took rhetoric in college, and it still did not prepare me well for asking questions and understanding where the starting point was. And it's important not to use, even if you think that you're using basic English words for any specialist or anybody. And this is attorneys and everybody else, accountants, life insurance salespeople, same issues. These words, oftentimes that are typical English words, don't mean the same thing that they would to a typical client or patient.
Sure.
Yeah.
They may be using the words different. They may be implying a different meaning to their words than maybe they're commonly understood as.
That's right.
Okay.
Nobody's trying to obfuscate. Nobody's trying to hide anything. But in order to get through your day, we take shortcuts. These heuristics and how we talk and how we explain things. We say it over and over again, sometimes thousands of times throughout the year. And so you kind of become numb to it's just like going through a drive-through. Just the automatic patter that somebody says, but we have to recognize who's in front of us.
Right.
And besides that, the person next to them. Sometimes they come with a loved one or an adult or a child, etc. That's next to them. And I will speak one way to the patient. I'm always looking at the patient, in my case, patient, or the client, stuff like that. Then I'll look to the person next to them who may have a different understanding or different background, and I'll explain it somewhat differently. But I always talk to the patient first and explain it. And I have to have the body language, the eye contact, the nod.
Right.
They're asking appropriate questions, that et cetera. And occasionally, whenever I've had problems in the past, I'll ask somebody to say back to me what I just told them instruction-wise in their own words, not just mimic my pattern and stuff like that, so I can catch understanding. But and that's, by the way, that's one of the things that we do for competency. Jumping off subject, competency, not statutory competency, not through the legal system, but medically. We want, when we talk to patients.
Say what you mean by competency.
Yeah, this is mental competency.
Okay,
that's a good question. Yeah. Mental competency is whenever I'm explaining something to somebody, informed consent, or if I'm going to do procedure or sending them for a procedure, or I'm explaining a medication, or et cetera, or a lab result. I want to make sure that they understand, and I'm the one that has to gauge their language ability, their background, their history, et cetera, and then use my abilities to explain it to that person, or sometimes write it down for that person, or explain it to that person, then also explain it to their caregiver, et cetera, so that somebody else knows, and they can explain it further once they step away from the office.
It sounds like you're explaining a very conscientious approach that probably not all physicians and healthcare professionals adopt.
Yeah.
But it's good to hear your thought process, because as patients, we can know to advocate for ourselves in this way and ask for clarification on some of these things.
Yeah. I hate to say this, and every time I talk with you, Vanessa, I think about another blog. Once the patient walks, I'm going to talk patients. Once the patient walks into your office, I'm talking when I was a primary care physician, they're technically on your clock. I know you're supposed to be there for the patient, but I'm going to be honest. The doc is the one that's got a list. The patient has their stuff to do for that day, but the doc also has the stuff to do for that day. And the patient may come in with a list of concerns and a bunch of questions, and may be organized or disorganized. They may bring in another person with them. So if the doc's running late, that sometimes cuts into the patient time, which unfortunately means that the doc tends to be a little less didactic, a little less explanation, a little bit less, maybe a lot less ability to slow down and discuss, and to look for body language signs that the patient understands, the patient is comfortable, et cetera.
Probably more prone to oversimplifying then, right?
Sometimes not explaining or oversimplifying.
Yeah.
We'll cut out all the third and fourth problems that maybe come from a drug, and just give you the first one or two that are most likely to happen, for instance. So, yeah.
Okay, so then that kind of rolls into the next category of topics that you write about here, which is basically diagnostics. So meaning statements a patient might hear from the doctor when the doctor is either trying to determine a diagnosis or have already landed on one. So I roped in statements about testing as well to this category. So
sure.
Let's start there then with routine testing. So what does a normal or negative result on a final report mean for a routine test?
Yeah, all patients want the ability to breathe a sigh of relief if they're waiting for a test result, blood work or chest x-ray or imaging or anything like that. And the word normal or negative does not always mean what it says. Normal or negative, let's start back up. Every test has limitations, whether it's blood test, x-ray, PET scan to look for cancer. Every test, stress test, mammogram, every test has limitations. So even if a test is normal, a stress test is normal, does not mean that you don't have any heart disease, or does not mean that you don't have any heart disease to explain your symptoms, your palpitations or chest pains or whatever. So that's part of the problem, and doctors don't explain that. Mammograms for many years, before we had 3D mammograms, had a 4 to 8% false negative rates.
Wow.
So before we had more imaging, more image quality, this is only until 5-8 years ago, we would, when we told a woman typically that her mammogram was negative for the year, the screening mammogram, what we didn't say, and it was written on the bottom of the report, most breast radiologist would write at the bottom of the report, with this technique, there's a 4 to 8% chance of missing breast cancer. More so in women who are younger, who had more dense breasts, had more fibrocystic breast lumps, et cetera. And so what women hear is negative, but what they don't understand is 4 to 8 out of the 100 negative people, 4 to 8 of them we could be missing a lump that may be of significance. Wow. So that's and we've improved on that with more recent breast techniques. But so when you hear the word negative, you actually have to ask more about, what did this test for? Does this explain, does this mean I'm okay for the rest of the whatever week, month, year,
right?
Et cetera. And so that's the same thing. That's the same with anything: stress test, mammogram, cholesterol panel, et cetera. Yeah.
Yeah. So then there's two more here that you write about. So maybe, a patient wants a more accurate and definitive test, and occasionally they'll be told, we ran a genetic test or a send out test, and it, shows whatever results. And then also on the flip side, that if the patient almost has their concern dismissed because the test, didn't show anything, or exam was negative, and there's kind of nothing we can do about your symptoms. So talk about both of those.
So so sometimes it sounds fancy to say we got an MRI, we got a nuclear medicine study, we did a send out test. That means they had to send out to a specialty lab, or we did a genetic. All the people that hear nowadays, genetic testing and et cetera. So sometimes. Just the fancier the technology, or the fancier the terminology, does not necessarily mean that we're getting data or information back that is helpful or answers the question that we posed.
Ooh.
A lot of times docs don't always, many times, occasionally, I'll get into trouble here, docs will order tests that are not quite right for the patient's needs. Their screening needs. Screening means you don't have any symptoms but at risk, or diagnostic needs. It means you have symptoms.
Yeah.
So sometimes that's not, so a lot of times doctors will order on a female with, 45-year-old female with chest pain, who has two risk factors for heart disease. They'll sometimes order a standard treadmill test, because the resting EKG is normal, and but sometimes that is an increased risk of false negative results for that woman, and so sometimes that woman needs something else, stress test plus some sort of imaging, stress echo, stress thallium. So you have to be careful. Just because somebody ran a test or ran a fancy test or an expensive test doesn't mean that it's the right test. Doesn't mean that they got the results back that helps explain your symptoms or your risks.
I think that point about the fanciest and most expensive test is definitely not necessarily going to be more conclusive or definitive or useful in diagnosing whatever your problem is. And it's okay to think through that lens and ask those questions to your practitioner.
That's right. And sometimes just ordering a battery of tests. So now what we've gotten to is we call the shotgun method.
Yeah.
You just got, if you have diarrhea, I don't even want to listen. I'm just going to order a bunch of tests that look at your stool. And then if it's negative, I'll say, I don't know. Then maybe I'll slow down and listen. So that's oftentimes that have a respiratory panel for respiratory viruses. So they don't slow down and think that maybe a lot of times you don't need that test, or it's not going to help me make a different decision. Are you going to get better? Most likely, if you're young and healthy, you're going to get better without any fancy testing from me, or from the emergency room practitioner. So that's some of the stuff that we run into. Don't be wowed by the fanciness of the doc, or the fanciness of the university, or the fanciness of the expense, et cetera.
Sure.
Insurance companies, by the same token, we talk. Insurance companies tend to abide by evidence-based medicine. So they tend to, whenever they approve or don't approve something, they say, you can go to the test, but we may not cover it. So one of the things is that they tend to abide by evidence-based. For instance, an MRI for somebody with low back pain that's otherwise healthy and has no risk factors for anything bad like cancers or fractures. No insurance company will approve an MRI for several weeks to months, after you have initial injury or initial pain. You have to try several conservative things like physical therapy and et cetera, and then maybe they'll approve it. And sometimes not if it doesn't do some other features. And this is not something that they make up. This is something that they abide by. That's evidence-based. That's been research-based. By the same token, sometimes whenever you've done conservative treatment options, this conservative means less expensive, less invasive treatment options or diagnostic options. sometimes they still won't cover it, in which case then your physician or practitioner has to go to bat for you to explain to the insurance company why you do need the update, the fancier test, the more advanced test.
So it sounds like it takes a good practitioner to kind of walk you through those steps and help you get to the point of maybe getting that fancier diagnostic test.
I want patients to know that I want them. What's happened over many years is that we think that the electronic medical record is kind of keeps the storyline going in terms of your sometimes multi-week or multi-month.
Yes, that it's
process.
A narrative.
It's a narrative in there, and anybody can find it. Any practitioner can just read it and get updated. But it really, what all of us recognize as we grow older is that you really need somebody who knows you. Not only has it recorded the electronic medical record or electronic health record, but also knows you, not just reads it off the record, to understand these chronic issues or things that are getting worse in terms of symptoms or not getting better with the treatments. You really need somebody who kind of knows you, not just reads the record.
So that kind of relationship with somebody is it's going to help you in these situations where you have received negative test results and you still have some sort of symptom.
That's right.
So a good practitioner is not going to say there's nothing else we can do. There's, and nothing's wrong. Dismiss you outright.
That's right. So there's a reason for everything, and sometimes the reasons are psychological. In the old days, we used to call it the derogatory term supratentorial. It means in your head and stuff like that. And true, everything is in your head, but it's biologically in your head. And so your big toe hurts. It transmits the pain up from your spinal nerve.
Perception is reality, right?
It transmits up your spinal, up to your spine, up to your brain. Then you perceive it, and so if it's from gout or if it's from neuropathy or whatever, there's a reason for it. Just because our tests don't show what the cause is, or the physician hasn't listened or can't figure it out, or they have not passed you on to another practitioner or specialist, doesn't mean that there's no cause. By the same token, when we've done the appropriate testing, people have listened carefully, and there is still symptomatology, then some people say, there's maybe a psychological overlay, et cetera. So I always want people to understand it's not either or. Sometimes it's and.
Sure.
It's not physical or psychological, but it's both.
Both and, yeah. Okay, so then how about this then? When a patient hears back about a test result and there is some sort of abnormality, right? And sometimes they may be, we can be told, oh, there's a little something on your X-ray or mammogram or scan or whatever. Again, is this another case of oversimplification, or what's the doctor, radiologist, or whoever that's explaining this? What are they trying to do by using that phrasing, and what do they really mean by it?
Yeah, so unfortunately, a lot of times test results are received over the phone or through electronic means. The patient can look in their patient portal or patient record and can see the reports from the radiologist, et cetera. So sometimes there's not an educational component, or it's minimal. It's not face-to-face where there's a back-and-forth conversation about what does this mean and what if and what that, and so because that takes time.
Right.
If a physician orders 100 tests per week, and even 10% of those come back and they need to have appointments to sit down and talk over the results, they'll swallow up their whole schedule eventually.
Yeah.
So we have to take that into account. But oftentimes whenever they could call in the old days little white spots on MRIs in the brain, UBOs, unidentified bright objects. We have crazy terms for these things. We have better terms for them nowadays. But Ditzel, we used to call it Ditzel, a lesion. Oh my gosh.
Okay.
It sounds terrible. So you have some sort of terrible pox on your life.
Yeah.
But the quickie answer is some of those are mixed terms, medical terms with jargon. So you actually have to ask, what does it mean, a nodule in my lung?
Right.
Is it a nodule? You and I may say, so my gosh, it's something I can see.
A nodule.
It's maybe down to a millimeter. If it's a CAT scan or MRI, that's a part of the problem with the fancy testing we have nowadays. We can see things down to a millimeter or two on your CAT scans, your brain scans, your chest scans. So a lot of times it means nothing. That we call them red herrings. We didn't expect to see them. They're not causing any problems. Right. But you have to explain it to the patient because it'll be in the report. Oftentimes oftentimes, and sometimes they'll want to follow up, even though it was not what we went looking for. Now that we have this, now we have to follow it up, sometimes for months to years. For instance, for lung nodules in former smokers, sometimes we have to follow them for several years with repeat scans. So even if it's something benign, or eventually we find out it's benign, it means it's not going to cause any problems, we sometimes have to bring you back and spend money for long periods of time.
So then on the flip side of that, then, so, you know, what if a patient has been coming in for something routine, mammograms, pap smear, something like that, and there's a one-time abnormal lab result, and it's kind of presented to them, but in isolation, you know, from all of the other previous results. What do you make of that?
Yeah, so we take it. So that's always the question: is the last one that was normal and this was abnormal? Which one's right? Was it abnormal last time we didn't pick it up, or is this abnormal one that's this time is it actually normal? So you don't know what's what. So oftentimes you'll see whether it's a lab result like a sodium or potassium, you'll repeat within a certain amount of time. Some things will repeat quickly within a few hours of getting it back. A potassium level or a blood thinning time, pro time for Coumadin, for instance. You know, as soon as we find this abnormal, we have to repeat it pretty quickly. Other things will say, oh, there's abnormality on your mammogram. It's not, you know, you're low risk. It's not that suspicious, but wasn't there before. Please come back instead of a year. Please come back in 3 months. So that's all. These are really extremely important. And it's extremely important for the patients to know what results are supposed to be coming back so they can look for them. Don't always rely that the radiologist or the practitioner who ordered the tests are going to tell you what the follow-up is. Some things get lost in space. Despite all the fancy electronic records and ways of keeping track of things, some patients don't hear the reports back, or they get partial results, but something is delayed. So oftentimes, for instance, in the old days, we'd get all the lab results back from blood work, but the prostate number would not come back until later. And that you'd get a call, a male would get a call, an elderly male will get a call about all the other results that were okay, but they wouldn't hear about the PSA, and that would get lost because it came in late and separately. So it's much better now. We have better systems, but I want patients to understand what they're getting and what's in totality, what should be coming back. Sometimes it comes back pretty quickly in a day or two. Sometimes it takes a few weeks, depending. And so you have to stay on top of it. And sometimes with the patient portal, it's much easier. You kind of know what's pending, et cetera.
Right. Okay. So then. You know, we've taken all the tests, we've, you know, done all of the things, and a patient is still continuing to have this symptom or whatever. So you write one here about the medical professional performs a psychosocial review, and, you know, once the tests have come back negative and they're still having symptoms, and the professional may state, I think your alcohol intake may be contributing to your whatever, anxiety, depression, diarrhea, headaches.
That's right.
What should we make of that in terms of, you know, diagnostics? Yeah,
so some people think it's a wastebasket, you know, diagnosis whenever you claim it's your depression or it's your irritable bowel or it's your fibromyalgia.
Oh, of course it must be my drinking. You just want me to stop drinking or smoking or whatever.
That's right. So for me, and once again, a lot of stuff is relationship based, and this is hard to do whenever you're going to an urgent care or somebody you see intermittently that's not your regular practitioner, doc, or nurse practitioner or physician's assistant, because you need a relationship to understand that it's not what you expect. It's not cancer. It's not this. It's not that. It may be that you're really depressed, or you're really anxious, or you're very obsessive, or you have an eating disorder, or you have something, you know, or you have abuse from in a relationship that's contributing to your insomnia, your weight loss, all this stuff that we went looking for medical causes, physical causes, and we recognize that maybe there's a significant psychological cause or causes.
Absolutely. Yeah. So then what about, you know, I think as patients we can sort of dismiss input like that, but also that, I mean, many of us have been dismissed when we say, oh, I've been looking on the internet for some of the answers to my question, and these are presenting some of the things that I found, and the doctor sort of replies like, I'm the doctor, I know more than the internet.
Yeah, and so I love patients going onto the internet. It never bothers me because I don't know more than the totality of the internet. What I do know, I have wisdom about you. So it's not that I know I have encyclopedic knowledge, which is what the internet does, but what I do is have wisdom to how to pare things down about you. And some things that people bring up, I'll say, oh, I'm not sure. Let me curbside or stop somebody and ask a specialist about this, or let me send you to a specialist about this, or let me ask, now that you bring this up, let me ask about your family history, or, you know, so it opens up doors. a lot of this stuff is dependent on the doc having time or being able to, or being sharp enough to know how to organize things. Because unfortunately, we call it hand on the doorknob. The doctor's stepping out the door, and the patient brings up these worries, these concerns, these things that they read, the things that their family told them, etc.
Sometimes the most important things.
That's right. Yeah. Unfortunately, that becomes a medical liability, because now the patient has divulged something to you, but you've already been running late. You may have been running late to see them, you ran late because of them. But the end result is now you have some more information that needs to be pursued. Mm-hmm. So oftentimes the doc will say either make an appointment, come back, or they'll say, let me send you to a specialist then, and stuff like that. Or unfortunately, too many times the doc will just kind of ignore it and say, no, that's not it, and move on, because they already made a decision earlier in that visit.
I think this is a good time to pause and put a reminder in there about the question that you answered in our very first episode, which is, why does my doctor's office take so long to get back to me? Mm-hmm. Or why is my doctor always running late? Like, these are the dynamics that they're dealing with, and patients have lots of questions, and that those decisions have to be made quickly and in the moment about, am I going to spend extra time on this with this patient, or am I going to shortchange someone else over here? Yeah. And it all factors in.
Yeah. It's hard to ask patients to list all your questions and problems before the doc or the nurse practitioner or physician assistant walks in. It's hard to say, list everything. Sure. Or I had many years ago, one of my colleagues, GYN, said, I can only take care of 3 problems per visit. If you have any more problems, you need to make another appointment. Wow. So people do some ridiculous things like that, but in reality, we're not working on an assembly line. It looks like an assembly line. If you look at your schedule, you have 10, 20, 30, 50 patients, whatever. Yes, some physicians have 50 patients if they're doing lots of routine wellness and small automatic things that they can churn through the patients' follow-ups, etc. And this is even without nurse practitioners, without physician assistants. But most primary care physicians are seeing, anywhere from 15 to 25, 30 patients per day without the help of nurse practitioners, et cetera. If they have more than that, they usually need assistance, or they're working, beyond 12-hour days sometimes. Yeah. So all the stuff requires time, right? And being aware that these things may be behind the obvious, what's obviously on the table in terms of symptoms and in terms of test results, that there's some stuff hidden that the patient's not aware of, or the patient doesn't want to divulge, et cetera. Yeah. Okay,
so let's move from diagnostics and testing to more treatment now at this point. So a patient waiting for guidance for treatment. So they say they have a new diagnosis. They may be told, studies on thousands of patients shows blah, blah, blah. And so this is what we need to do, what we need to start, what we need to avoid doing. Why is it formatted that way when the doctor is giving information on the treatment? What are they trying to say?
So we'll do a whole podcast on statistics. So whenever people quote studies, there are usually dozens, if not thousands, of patients in a study. The idea is that you are one of those patients that would fall within that study group. Let's pretend that. So if they did it for women between the ages of 15 and 45, and they did a study about bone density, premenopausal bone density, the assumption is that you're between 15 and 45, you're a female, that this study would apply to you if the question came up, stuff like that. Now, so unfortunately, sometimes only just one variable would throw you out of that statement. So if you were a heavy smoker, and the average smoking between age 15 and 45 for that group that was in the study was, none to half pack a day, but you're a heavy smoker. Smoking, for instance, increases your risk for bone density problems later in life. So that would automatically, the study that they quote would not apply to you. And so they have to be very careful about whenever people quote studies, if it actually, number one, applies to you, if you would fall within the parameters of the study group. The next thing is, even if you fall within the parameters of the study group, we don't know if the negative, some of the people will not have gotten a benefit, or let's pretend from a treatment protocol. We don't know if you're one of those people that would have not gotten a benefit or would have gotten a benefit. So, they said, there's a benefit of 35, improve in bone density by 35%, blah, blah, blah. We're not sure. Okay, yes, on average, this helped women that, had low bone densities and whenever they're premenopausal, et cetera, to to avoid osteoporosis postmenopausal, but we're not sure where you would have fallen within that group. So you would have belonged to that group for that test group if you were in that group, but we're not sure how that result would have benefited you. And this is the problem with immunizations, et cetera. On average, immunizations that are appropriate, CDC and FDA approved, on average, they help the vast majority of the population. Small percentage of the population, it doesn't benefit, and another smaller percentage, it may actually may do harm. So that's one of the problems that we have whenever we talk about any statistics, is we don't have the error bars or the standard deviation. Right. And that's a humongous problem, I think, and that's why I believe people don't understand why, for instance, one of my colleagues, who was an anesthesiologist, needed hepatitis B vaccinations. These are standard now for kids for a couple of decades, and he already had a standard 3, and we checked blood levels to see antibodies that were negative, they were not undetectable. So was not immune, and so we gave him one booster, was not immune, a couple weeks after the booster. So we gave him another round, another 3 shots, and he never was able to generate antibodies.
Wow.
So he's one of those people that does not generate antibodies to the type of hepatitis B immunization that was available at the time. So he's one of those rare people, but it affected him because he deals with blood, et cetera. He's an anesthesiologist.
Sure.
So, he has to take extra special precautions. So it's rare. We still give Hep B. I got my Hep B. We give Hep B to children before, school-age children. It doesn't mean that we should get rid of it, but we have to recognize it doesn't help everybody, for instance.
Yeah. I mean, that's exactly what you say on here, just the danger of, summing up the cost, the risks and benefits for a treatment just in a single number. Like, it helps, 73% of patients or whatever. And that leaves the patient walking away thinking, oh, I'm probably in the 73% and it's probably going to help me all the way.
That's correct.
I don't need to do any follow-up or worry.
That's correct.
Yeah. Okay. So, then continuing on treatment. So let's say, we need a surgery, for example, because there's something cancerous or a tumor, and the surgeon says, we got it all.
Right.
We got it all. 100%.
Right. Yeah.
What does that mean?
Yeah, this is variable because we now have better technology. Typically, that's what the surgeon was able to see at the time of surgery with their eyes, with their magnification, whether they had loupes, which is magnifiers that they put on the glasses, or their naked eyes or standard vision. That's what they typically mean. Sometimes it means that they did a dye study intraoperatively, and they could see more, et cetera, or they did an MRI intraoperatively for brain tumors, and they got it all according to what the MRI showed, but does not talk about microscopic stuff that you would may spread, for instance, through the lymphatics to distant sites. You can't see that.
So it seems like a critically important qualifier.
It is.
Couldn't you just say we think we got it all, or based on everything we can see, we got it all?
That's correct. And you can modify it with a few words. That's correct. And and if somebody questions that, you can add a few sentences. This is what we were able to do intraoperatively. We know that the stage may not be, not be curable or stuff like that, but we have to debulk. We have to take out the primary tumor, and then and the pathologist will let us know some, et cetera, some extra stuff, and we'll know in a few days. Right. So adding that makes a big difference and sets expectations appropriately.
Absolutely. I mean, and even, further on expectations, you write a couple of, misleading phrases in here about, end of life care. So, one is, a patient has a poor prognosis or they're near terminal. And the patient and family may hear, we want to shift our focus to comfort and achieving your goals. Like, what does that mean? What kind of expectations are they trying to set there?
Yeah. So when sometimes physicians or nurses will tell a patient, do you want to go back to the hospital? The person is their primary care physician or specialist have given him less than 6-month prognosis to live, so that qualifies them for hospice in the United States. Medicare covers hospice for prognosis made by 2 physicians for the patient to live 6 months or less. But whenever you say, do you want to go back to the hospital, for some people, if they say no, sometimes they think they're just going to get just as good a care as going to the hospital and getting chemo or surgery and stuff like that at home. home. And the answer is, what you're telling them is that we're going to, if you're going to have symptoms that you're going to be terminal, pain, shortness of breath, we're going to take care of it at home with morphine or Valium products, et cetera. So we have to be careful that we explain things. And once again, a lot of our patients are demented or they're delirious, so they don't understand everything. So you have to explain to the nurse, or the doc has to explain to the family. This means that we're not going to be calling 911 if they're short of breath like they have been in the past and going in for 2 weeks for antibiotics or stuff like that. So we're going to keep them at home, and we understand the natural progression of the disease or diseases is going to take their life. So that's important to kind of say that out loud. And once again, it's the timing and how you say it and who says it, et cetera, who's listening makes a difference, obviously.
But the goal there of, about achieving your goals is, avoiding dying in a hospital or, some major surgery that you couldn't recover from, or.
That's right. Yeah. That's correct. And so I think we have to define, a lot of it is listening to the history of how the patient got to this point and what's been tried, et cetera, and understanding what the patient and their loved ones' belief systems are and value systems are, and then understanding that hospice is not always right for everybody, even if they have less than 6 months to live. Yeah. Hospices may not be right according to what the values and what the belief system of the patient or their relative, their healthcare power of attorney, who speaks for the patient, who may not be able to speak for themselves. Sure. So it's extremely important to kind of be clear. And most people are. Most people have come. It's not an acute problem. It's usually a chronic problem.
Sure. And of course, too, there's not malicious intent from the healthcare professionals in bringing these things up. They're not throwing their hands up and saying, we give up on you. There's nothing else we can do for you. Now we don't want to treat you anymore. That's not what they're saying.
When people say, I want to have hope, we want to say, before it was hope for cure or hope for extended life. Now we're hoping that to not go back to the hospital and to have more relief at home with people around you. So the same word hope, one was hope for a cure or for remission. Another hope now is for more family around you and less time in the ambulance.
Sure,
and,
a peaceful end.
Right, and so we need to use the word, even though it's the same word hope, it's quite a bit different meaning.
Sure.
And unfortunately, some of these things happen overnight. One day you're going for chemo, one day you're going to the hospital for your pneumonias, the next day we're going to stay home and we're going to treat you at home.
Powerful stuff. Okay, we're going to move on to the final category, which is medications. And obviously there are overlaps with treatment here too, but drugs can be a particularly confusing area for patients, and one that oversimplified explanations from medical professionals can really make worse. So one example that you put in here is when a patient wants to know how a medicine is going to help, they may be told, quote, the mechanism of this drug works, blah, 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 and the why it helps is, so-and-so explanation. Why is that the way that doctors are explaining it to us, and what are they trying to tell us by explaining it that way?
So in med school, we were taught mechanisms, and then certainly whenever the new drugs come out that were not available whenever we were learning about medicines in med school, we learn about them oftentimes in conferences or from pharmaceutical representatives.
What is the mechanism? Will you tell me what a mechanism is?
Mechanism is just how a drug acts in your body to cause the benefit that we're looking for. That's all. It's how does it work in your cells? How does it work with your electrolytes? How does it work with your neurotransmitters? How does it work to get me the result that I want?
Okay, right. That makes sense.
Right. So what happens, unfortunately, is that we hypothesize, we postulate from research and stuff like that, sometimes on animals, et cetera, how something gets to the effect that we want, that allowed to get FDA approval, for instance.
And that's good enough. The postulating of how something works is good enough to say that it will likely work on something and then get it approved?
Yeah, so that's a good point. The FDA doesn't necessarily always have to have mechanisms. That people put the mechanisms that are putative, that are supposed to be happen, but what the FDA is interested in is toxicity, and efficacy is what they're interested in. And so toxicity, how many people it may hurt, and side effects, and then efficacy, how does it get the result results of clinically significant results, statistically significant results for the disease that there is being treated or the symptom that's being treated.
Right.
So it doesn't. A lot of times we don't know how medicine works, or we think we know, but many years later we realize it's not the way we thought it worked.
Yeah.
So it doesn't mean that it doesn't get FDA approved. It doesn't mean anybody lied. It's just that when we explain that to the patients, we should say, we think this is the way it works, but a lot of times years later we realize it's not correct. It still works,
sure,
but it's not the mechanism.
So just like that, possibly incomplete understanding of the mechanisms, there's also possibly an incomplete understanding of the side effects, right? Which is what, sometimes you write this one too, that a patient might hear, from their doctor, in my, 30 years of practice, I've never heard or seen your side effects due to this drug before.
That's right. So unfortunately, even a doc of 30 years like myself has not had millions of doses of SSRI like Prozac.
Right.
I've had people take thousands, but not millions. And some of the very rare side effects only show up whenever you have the millions of doses, not the thousands like I have in my experience. So you have to sometimes, and that's the same thing with the immunizations. Whenever they do it on thousands, but you see select types of side effects, adverse effects, and then when it goes to millions and tens of millions and hundreds of millions, that's when you see some very, very rare effects. But you couldn't pick it up with just thousands of doses.
And a good physician will have the cognitive humility to admit that there are limitations and definitely possibilities for side effects that may be even unknown and won't dismiss you outright.
That's correct. We should write it down as possible or patient reported if the doctor didn't witness it themselves, etc.
Sure.
That's correct. And there's something called personalized medicine that's been coming out now for several years. The idea that we're going to have better ideas about how your genes and your proteins and work with medicines, etc., so that we know certain medicines will work with you and have fewer adverse effects than other medicines. And that's the here and now, and in the near future, we'll have more personalized, directed treatments. Yeah.
Okay, so we're going to close it down with some talk about drug cost. So there's kind of two things that you have on here. So, we can be told, this is the medication that you should use. This is going to work for you. And the doctor can say, don't worry, this drug is on your formulary. Or this drug is generic. Like, what are we being reassured of when we hear those things? And is it an automatic guarantee that we should go for that medication?
Yeah. The word generic, people equate with cheap or inexpensive, and oftentimes they're not, especially the first few
or even
years.
Less effective sometimes. Yeah,
it's pretty. FDA allows, I think, a 20% leeway in bioavailability. So I think it's 10 or 20% more bioavailable or less bioavailable. This is absorption into the body,
depending on the formulation, if it's brand or generic.
Right.
Okay, yeah,
bingo. Compared to the name brand, and for some people that makes a difference. Some people they can feel, they sense a difference. It's not as effective, and so we have to be careful, not just poo-poo patients about that, and just dismiss them. And just because a doc has samples or it's a new expensive drug doesn't mean that it's the right drug or the best drug for them. But oftentimes that's what physicians or practitioners are trying to do, is save on costs.
Sure.
Patients requested it. It's good stewardship of people's of money, etc. So
right, and that's definitely a value that patients hold for sure as well. Right. So then, what about this drug is on your formulary? What does that mean necessarily?
Right. Yeah. So I mean, the idea here is that the pharmacy benefits company. This is not not the big pharma, but the pharmacy benefits company, a middleman, has decided that out of all the drugs for a class that they've selected one or two or three to put in your formulary that the doc can pick from, that will have a better copay, as opposed to not on your formulary.
So it's the menu of covered medications.
Right, that are better covered.
Okay.
Right, that's correct.
Gotcha. Right. All right, cool. Well, thank you so much for being our translator today, Dr. Tadros.
Well, hopefully it was a little more clear.
I think so. I feel a little bit less mystified about some of these phrases, and I think our listeners will too. As always, ladies and gentlemen, you can get involved with the podcast by sending us an email to notyourdocpod@gmail.com. You can send us your questions for the doc, your input, your feedback. We'd love to hear from you. Once again, that's notyourdoc@gmail.com. Thank you, Dr. Tadros.
Thank you, Vanessa. Very good questions. I appreciate it. Thank you.
Yeah, this was great. Thanks for opening up your brain treasure trove with this blog to us.
Yeah, it'll be fun to hear from listeners if they have questions.
Yeah, absolutely. All right, we'll be back next time for more.
Bye-bye. This previous podcast represents my opinions and the opinions of my guests. This is not medical advice, and I'm not establishing a physician-patient relationship with any listener. The content here should not be taken as medical advice. The content here is for informational purposes only, and because each patient is so unique, please consult your healthcare professional for any medical questions that you may have.